Yeah, can you become mute, please?
Yeah, I'm mute.
No, you're not. We are able to. Yeah, now you are.
No, I'm mute. I'm mute.
Yeah.
Enjoy.
So
Bye.
I can. No, don't say bye. I mean, you have to be online, otherwise the meeting will end.
No, I'm patiently listening. You continue.
Oh, thank you. Yeah, you can off your video also. It's kind of distracting because it is moving, if you know what I mean.
Yeah.
Yeah, thank you so much. And you are not mute. We are able to hear you. And now you are. Okay, thanks. Okay, so I welcome everybody for this obstetrics session. So I'm Dr. Shilpa from Bangalore, and this is Dr. Padmapriya, who is seen on the screen. She is from Glen Angels Global, Chennai. So today we'll be starting with instrumental delivery. Mainly, we will be discussing on forceps delivery. And this is only about the practical aspects of forceps delivery. We will not be going on with the indications or the details of the indications part and all that, the theory part of it. So if I can share my screen, yeah, I can. So as we know, the number of forceps delivery, or even for that matter, instrumental deliveries are coming down. This is mainly because of increased popularity of, say, cesarean, acceptance of cesarean, and also because of the litigation problems that the obstetricians go through. And in this era of modern obstetrics, there is no role for mid-cavity forceps. The only role is for outlet forceps. So the outlet forceps, as we know, it is a very skillful, skill, I would say, which is learned in our training programs during our post-graduations. And we kind of are quite well trained in our government institutions when we were postgraduates, both I and Dr. Padmapriya. This is one of our strengths, which I believe we have, and we have had numerous successful vaginal deliveries because of the instruments. And I am more comfortable with forceps delivery compared to vacuum, though vacuum delivery is gaining more and more of popularity now because of the ease of application. So this is one forceps delivery which I am showing here. I hope you can see the screen, Dr. Padmapriya.
Yes.
So here you can see that I will start from the beginning. So these are the two blades of the forceps. So I have applied the left blade, and now I'm applying the right blade. So you can see that the locking is quite easy. I have already given an episiotomy. So I start pulling on the fetal head. So here you can see that the pull is almost straight, and so the pull has to be downwards and backwards in the beginning, and then it has to be downwards and forward. So now I go downwards. So once I go downwards, you can see that the head is coming down, and the pull has to be done only during the contraction of the uterus. And during relaxation, we can either unlock the forceps blades and wait. So here you can see that the forceps is done, the head is delivered after the application of forceps, and I will deliver the rest of the baby as usual, as it is in this thing. So I will show you the forceps which I have got here. This is the outlet. Can you see?
Yeah. Yes. Yeah. We
So
can see.
yeah, this is the forceps which I have got. So it has two parts, the left and the right. So each part has the blade, the shank, and this shank determines whether it is outlet forceps or mid-cavity forceps or low forceps. So the shank of the outlet forceps is the smallest, and this is the handle. So there is a lock here. So this is how the forceps is locked. So before application of the forceps onto the patient, it is very important that we assemble the forceps and check whether the blades belong to the same pair or not. So if it is of a different pair, then it will not lock, and that is how we know that that this belongs to the same pair. So I always put the left blade of the forceps first. So I take the left blade of the forceps in my left hand, and this goes into the left side of the maternal pelvis. I take my right hand, I insert it between the maternal pelvis and the fetal head so that the ease of application is smooth. And I usually start the forceps application keeping it vertical. When I go in vertical, then I slide down into the lateral part of the pelvis between the fetal head and the maternal pelvis. And I ask my assistant to hold this handle and depress it. So then I bring in my right blade, which goes into the right side of the maternal pelvis, and with my right hand. So once it goes in, I lock the forceps. So once the forceps is easily locked, so then I start the pull. The main criteria for application or decision for forceps is the head should be on the perineum. The blades of the forceps should lock easily. The occiput should be just below the pubic symphysis in occiputo anterior position, or it should be in the posterior if it is occiputo posterior position. So the rotation has to be complete for the application of outlet forceps delivery. So this I will show it in another video again, what I have just discussed. So you can just see this. So this is another forceps application. See here, I'm assembling the forceps outside the pelvis, as in like just to check whether it belongs to the same pair. I have inserted my finger into the maternal pelvis between the baby's head and the maternal pelvis. So left blade I have applied, right blade I have applied. The locking is quite easy. And once the locking is easy, then I start the pull. The pull should be gentle. It should be the force only with our elbows. So there should not be like we have seen people like the obstetrician pulling and somebody pulling the obstetrician like, applying a lot of pressure. So once the baby's head smoothly comes out, so you can remove the forceps blade, and this is how the rest of the baby is delivered like usual. So this is again outlet forceps delivery, which I have shared now. The indications being like maternal indication where there is maternal distress, where the mother cannot push, as in like prolonged second stage, or it could be fetal indication where there is fetal distress, or an obstetrician distress wherein the obstetrician is getting tensed, and we apply the forceps and start pulling. So before we apply this forceps, what are the things that we look for? One is complete dilatation of the cervix has to be there. Second thing is the bowel and bladder should be empty, which I make sure all the time that I put a catheter to clear the bladder before I apply the forceps. There should be a legitimate indication to do this. And the rotation should be complete, which I think is very important for easy application and for easy delivery. The outlet should be adequate for the delivery of the baby's head. Apart from this, the post forceps application, so I usually check for vaginal tears, I usually check for the cervical tears, and document if there is any tear and treat it accordingly. So the post-operative care is nothing much. We give the episiotomy. I give the episiotomy before I apply the outlet forceps. But sometimes if I am in doubt whether I will be able to successfully do the forceps delivery or not, then I apply the forceps and I lock the forceps and I see whether with each pull the baby's head is coming down or it is going to be a tough forceps delivery. Only then I give the episiotomy after I apply the forceps. But otherwise, generally, more than in 90% of cases, I give the episiotomy before I apply the forceps. So for the outlet forceps, the head should be on the perineum, as I told you. The head should be visible even without separating the labia. and the rotation should be complete. So these are the main three things that I look for. Sometimes I apply a low cavity forceps also when I feel that the head is slightly at between +2 and +3 or at +2 station, wherein I feel I'm more confident in applying the low forceps. So that is one thing that I would want to mention. Anything else we can discuss over questionnaire? Yeah, Padmapriya, do you have anything?
Yeah, I have a couple of questions.
Hmm.
What you told about the prerequisites, right? For forceps application, right? You've told about the rotation should be complete. One thing is, do you check for the sagittal sutures and the anterior fontanelle before you place the blades, or do you keep your one of your fingers over the anterior fontanelle while placing the blades?
The majority of the times I will not be able to feel the sutures only because of
Yeah,
the caput and
careful.
because of
Yeah.
yeah. So I don't take that as a criteria to apply the forceps. For me, the main
So
criteria is after the whether it is an easy application, whether I have applied the forceps correctly, whether I'm able to put the blades easily inside the pelvis, and also whether the locking of the blades is easy. So those are the only two criteria that I look for, and I check for occiput. So occiput, if it is in just below the pubic symphysis, then I assume that the sagittal suture is in the midline.
right. If the blades don't lock, what are the reasons, Dr. Shilpa? Suppose you apply the blades and it doesn't lock.
So usually it is because we have not gone completely in. So we need to push it a little deeper into the pelvis. So my main thing is the ear has to be included into that fenestration. So
Yeah,
this is the fenestration. So the ear has to be in this fenestration. If the
yeah,
forceps is very superficial, then it will not lock. That is one thing. And the second important thing is the rotation. If the rotation is not complete, if it is not in direct occipito anterior or direct occipito posterior position, then the forceps blade will not lock. So I would never advocate you to start pulling or applying traction before the locking is complete. With incomplete locking, I wouldn't suggest to go ahead with the traction.
okay. But do you use mid cavity forceps?
I use low forceps, but I don't use mid cavity forceps. Low forceps, I find it very comfortable when the head is not at perineum. When the head is slightly at +2 station, I use low forceps, and I also use low forceps when I feel that the outlet forceps is very superficial. When I'm not sure that I'm not deep enough, then I use the low forceps because the forceps marks are lesser when I use the longer forceps. So
Yeah,
for me, I feel I'm more comfortable using the low forceps when there is big baby, when the station is at +2, and also when I feel that the rotation is slightly not complete. So if there is a rotation lag of say like around 25 to 30 degrees, then I would rather put the low forceps and apply the traction.
yeah, that is the main point I wanted. If it's short of rotation, low forceps. And I've seen you doing it on thousands of cases uh, during your post graduation. So, how do you document this whole process, and yeah, how do you document?
So documentation in instrumental delivery is one of the most important factor because of the litigation. So
Yeah,
litigation could be either in terms of like traumatic PPH, which can happen because of the vaginal tears or cervical tears, or it can happen because of the injury to the baby. It could happen because of the palsy, nerve palsy to the baby. So when we decide on to do the forceps delivery, documentation plays a very, very important role. Documentation should start from the complete monitoring of the labor, and it should, in the delivery notes, we have to first write the indication of the forceps. We have to write that all the prerequisites have been met with, and also we have to document whether it was a easy insertion of the blades, whether it was easy locking, and how many pulls we took to deliver the baby. and also post application or post delivery, whether there were any tears and how they were managed. So all these things have to be documented to make sure that legally we are safe when we apply the instruments. And also I take a consent, separate consent from the husband and from the patient before I apply the forceps, or even for that matter, even vacuum, or even for epidural.
Yeah. Do you take the consent just before application or at the time of admission for everything all to put together?
No, this
Like
is just before the application. I have had one or two patients who refused for instrumental delivery in my entire practice, in spite of struggling, in spite of explaining everything. So they refused to sign the consent, saying that they don't want to go for instrumental delivery, and they were okay with cesarean. Of course, like one patient we did cesarean, the other patient we had to give fundal pressure and deliver. But out of so many, few of them may refuse to give the consent. So I feel consent taking is very important, especially the specific consent which says that why we are applying, what we are applying, and what they are getting into when they agree to do it.
Yeah. Post forceps application and locking and before applying traction, do you check anything else?
No, for me, it is more about, once I apply the traction, the baby's head should descend down. So with each pull, the baby's head should come down. And we should make sure that if it is taking more than one pull, then in between the pulls, in between the contraction when the uterus is relaxed, we need to unlock the blades and relax it a little. But at the same time, hold the forceps so that the head doesn't recede back. So the station that it has come down, you need to maintain the head at the same station.
Yeah, that was one of my questions. In between the pulls, do you unlock the blades? Yeah. So how many pulls, doctor? What is the maximum amount of pulls?
Max I use 3 pulls. Beyond 3 pulls, I don't really go beyond 3 pulls. But I have done sequential application of instruments. I have done forceps and then brought it down, and then I have applied vacuum. But these are very adventurous and heroic things which we have been taught in our PG time. But I wouldn't really advocate unless you are very confident of doing it, and unless you have very strong strong backup of legalities.
Yeah. How much force do you use and where do you apply the force? Like chest, forearm, where do you apply the force and how much force should be applied?
So force application should be only from the elbow and the wrist. I mean, beyond elbow, I usually don't do it. I have seen people putting their legs onto the stirrups, they on the table, trying hard to take it out like it is some 100 kilos and all that. But I don't really struggle so much because of the judicious selection of cases which I do, wherein I know that, yes, I mean, this is going to be a successful forceps delivery because I'm more confident in forceps delivery than vacuum. And also I'm pretty confident if the head slides down along with my forceps pull. So for me, that gives me a lot more confidence, to continue with it. So many a times I have applied forceps and I have abandoned and I have taken them for cesarean. Many a times I have applied forceps, but the forceps blade has not locked because it is short of rotation. I have changed it over to vacuum with difficulty, but only when it locks and when the head comes down with my pull, only then I will go ahead with the complete procedure.
Wonderful. Now, how do you explore for the tears? Cervical, vaginal tears. How do you explore a complete exploration?
So once we have ensured that the outlet is adequate, and once we know that the baby is not too big for that pelvis, then the amount of tears or the number of tears in the vagina and in the cervix will not be much if the cervix is fully dilated. So cervix will not be there at all because we are doing only outlet forceps. So the tight fit between the fetal head and the pelvis, if it is not too tight, if your blade slides in easily, if there is enough space between the fetal head and the maternal pelvis, if the sliding is easy, then the chance of tear is very less. But if at all, if there is bleeding and if you want to check for tears, then you just have good light, have two assistants, have enough help, and start visualizing the tears, like using good lighting basically, and retractors, and if required, suction, where you suck out the blood which will be continuously oozing out, and with good retractors, I think you should be able to identify the tears. And I usually suture them with Vicryl Rapid with the round body needle.
You do that walking over with the sponge holding forceps?
Yeah. For the cervical tears, I use the leapfrogging technique or the walking over the cervix, where I visualize the entire 360 degrees of the cervix. And if there is any tear, then I use continuous sutures with either catgut or with the same Vicryl Rapid.
Okay. What is prophylactic forceps, doctor?
So prophylactic forceps is something where there is no obstetric indication, but you want to apply the forceps for a non-obstetric indication. Like if the mother has cardiac disease, if it is a previous cesarean, then you apply the forceps without an obstetric indication like maternal distress or fetal distress. So that is only outlet forceps. So I again emphasize that it is only outlet forceps and not low forceps or mid-cavity forceps.
All right. There are some from the inbox. Can we go through that? What are the injuries due to forceps? And in case of malposition, what will be the type of injuries in the baby? This is from the inbox. Yeah.
So I will show you one, this thing. Mainly it is about the marks, okay? I mean, nothing much apart from the marks. So I have had one Erb's palsy. So this is one mark where can you see this, Padmapriya?
Yeah.
So
Yeah.
this is the mark, okay? So this mark happens when the rotation is not complete. Can you see this mark? So usually these marks will go away in 24 to 48 hours once this is because of the pressure of application. So sometimes there may be congestion in the baby's eyes because it is very close to the baby's eyes, but all this will disappear in 48 hours. So how we counsel the patient, like post-delivery, once there is a mark, I mean, we shouldn't like start panicking. So I've had a laceration on the scalp, and see, none of the times I've had any problems in dealing with the complications, as in like injuries to the baby, because the patient's husband usually is inside the labor ward, and they see how much we are struggling to deliver the baby. The acceptance is quite good when it comes to like injuries, especially the blunt injuries.
Yeah. And somebody's also asked, when will you give the episiotomy, which you've already answered, but you can tell them. Maybe they joined in late. Yeah.
Yeah. So I usually give the episiotomy before I even apply the forceps. But when I am in doubt whether the forceps delivery is going to be successful or not, then I apply the forceps. I see whether the locking happens easily, whether the head will come down with each pull. Only then I apply the forceps. So with forceps in the pelvis, I give the episiotomy. So in that case, it is slightly little like, cumbersome because the blades are there, the handle is there. But you can still do it if you know exactly where to give. If you have given enough episiotomies, I think it's still easy to do it.
Yeah. Anything else from the chat box? Can you see, doctor? Any other questions we've not answered?
Any experience?
Madam, I want to ask something.
Yes, sir.
Yeah. Is there any role of using forceps in cesareans? I mean, we don't do so many vaginal deliveries like you, but high floating heads and all these things. Can the forceps be also applied in cesareans?
Yeah, we usually do it. I am more comfortable applying vacuum during floating head in cesareans, but forceps, yeah, I mean, I use single blade forceps when I want to lever out the baby's head. So this is called Vectis. But I'm more comfortable with vacuum. I know, I mean, I think you are more comfortable with forceps. I have posted a couple of videos also in Bangalore groups long back. I will post it again. Where I have used forceps for floating head in cesarean.
Right. And one more thing, this whenever we are trying to apply forceps, you mentioned about this, the paperwork which you are following and all these things, madam. Is there anything like a different type of forceps which is available? like something like a forceps which is low weight or Teflon coated or something like that. Is there something like that which is available, madam?
Sir, finding a forceps in corporate hospital where I worked itself was very difficult when I started my practice because nobody used to apply forceps in Bangalore. Not many.
Okay.
Sorry, not nobody, not many. So
Okay.
the one forceps which I've got is with stainless steel. This is what I use regularly. This is what I use even in in corporate setups. So I don't know about it. If you know,
So
if
we
you
are using one very nice lightweight, ultra lightweight Teflon coated forceps. Okay. I think I'll ask Vismay to send photo of that. But we
Yeah,
are using
please.
it only in cesareans. We don't know. I mean, we don't use it for vaginal deliveries. But I think we'll ask Vismay to send a photo of that.
You are
Okay.
very rich, sir. You can afford any kind of Teflon, even like, titanium and all those things. But for us, I mean, the stainless steel will work very well. We have had no
Yeah, yeah, yeah.
problems.
Next, I will buy gold plated forceps. Okay. Hmm.
Yes, sir. Yes, sir.
Yeah.
So conducting normal deliveries or vaginal deliveries with a healthy baby and an untraumatized baby defines the skill of an obstetrician. And I think that is where the skill of an obstetrician is highly tested. So I urge everyone to kind of get trained. I know, I mean, it is a little scary to do it on your private patients, but once you start doing it after observing one or two cases from your seniors or from your colleagues, I think it is worthwhile. And forceps has been, I think, championed and condemned at the same time. Like it is like a yo-yo. So when you have successful vaginal delivery without any complications, you kind of cheer for the forceps. But when you have complications, either with the injuries to the baby or with regard to the tears, you kind of start condemning as to why you did instrumental delivery. You could have done cesarean for the same. But I think it is one skill, I think, which every obstetrician should have to establish her practice, because the success of a vaginal delivery, I think only a good, well-trained, well-skilled obstetrician can give, and no surgeon can do it. So this is,
Absolutely.
yeah. So you want to give any remarks, Dr. Padmapriya? I think you do a lot of high-risk deliveries at Glen
Yeah,
Angels Global, and you
yeah,
must have seen all kinds, referred cases and all that
yeah.
thing. So
For all high risk, like most of the high risk, right? Like cardiovascular diseases, we apply and preterms, we apply. There's no issue as such. As you said, the husband is always inside and they see the efforts that we do.
yeah.
Here, instrumental deliveries, yes, is quite high because of the high risk pregnancy. But well done, Dr. Shilpa. I've seen you personally over years. Knowing you for so many years now, more than 27 years, and I've seen you applying low forceps like a piece of cake. And well done. Coming from you, I think this is very important for everybody that forceps is a skill that should not be forgotten. Yeah.
Yeah. Thank you so much. Thank you.
Thank
Thank you,
you.
Dr. Jay, for
I want to thank Dr. Shilpa and Dr. Padmapriya both for conducting obstetric master classes, because I think it's a very, very important thing to conduct, because I think a lot of young juniors, especially people like us, are not at all trained into doing forceps and vacuums. And to be very honest, people like me especially are very, very scared. That is because we do not have that type of uh, experience or courage or whatever. You give us a ureter and aorta and all these things, we'll knock it out and again suture it back. But when you put forceps, I think Dr. Shilpa and Dr. Padmapriya will also request you to have sessions on skull and pelvis, because what you mentioned and what I was listening and what my kids were listening through the car is that assessment of the head and rotation of the head is very important part when you want to apply forceps. So I think we must have some probable sessions on that if you can do something. And how to assess the rotation and mal rotation, and uh, from the vagina, because all that is very important to assess prior to the having the delivery. So I think something like that is going to be worthwhile.